There are multiple facial pain disorders that affect the temporomandibular joint and masticatory muscles. Let's discuss one of them in today's video. The topic of today's video is retrodiscitis. It is an inflammatory intracapsular temporomandibular joint disorder which is characterized by inflammation of retrodiscal tissues. Retrodiscal tissues are the tissues that join the disc to the posterior surface of the condyle and the tympanic plate. These tissues are highly vascularized and innervated. Now, how do they get inflamed? Will tell us what causes the disorder. Let's discuss what causes retrodiscitis. The first and the most common cause is macrotrauma. A fall, a blow to the chin, or a road traffic accident may force the condyle right into the retrodiscal tissues, causing inflammation and resulting in retrodiscitis. The second most common cause of retrodiscitis are disc derangement disorders. Disc displacement with reduction or disc displacement without reductions, wherein the condyle actually sits on the retrodiscal tissues and functions over them. These tissues, being highly vascularized and innervated, are not supposed to take the functional loads and hence get inflamed easily and produce all the painful symptoms. The third cause can be parafunction in a pre-existing disc derangement disorders. Some patients might have a clicking joint or a reduced mouth opening wherein the disc is displaced permanently. These patients might not be knowing that they actually have a disc derangement disorder unless they go through a phase of increased emotional stress wherein they start parafunctioning. An increase in loading over the adapted retrodiscal tissues, which were taking the occlusal loads till now produces inflammation. This may cause retrodiscitis again. Sometimes these patients might be taking certain drugs to treat certain other disorders whose side effects can be an increase in parafunction, and this might actually aggravate an already existing disc displacement disorder and cause retrodiscitis. The fourth cause can be a spreading infection from adjacent tissues. The most common is an ear infection spreading to the joint. This may cause inflammation and result in painful symptoms of retrodiscitis. Now, after discussing all the four causes of retrodiscitis, let's discuss the presenting symptoms of this disorder. This will be followed by video history of a patient who will tell you all these presenting symptoms in her own words. Whenever patient comes to you within 2 to 3 days of development of retrodiscitis, the patient will complain of pain right in the temporomandibular joint area, pointing the fingers specifically over this region. They will complain that the pain is usually constant and increases with function. They might also complain that the teeth on the same side do not fit together properly, and any attempt to make the teeth meet together, like in chewing or on clenching, produces sharp pain in the TM joint area. They may also tell you that the teeth in the front meet heavily, or they may tell you that the teeth on the opposite side meet heavily. Sometimes the patient doesn't understand all these occlusal changes very well, so they might report to you that they feel that the bite feels a little different. However, on clinical examination, you might feel that the occlusion feels absolutely normal. Why does the patient then feel that the teeth on the same side do not meet? That is because the inflammation in the temporomandibular joint pushes the condyle downwards and forwards the articular eminence. This rotates the mandible towards the opposite side, and hence the teeth on the opposite side or on the front feel to be contacting heavily, and on the same side feel to be not contacting the way they usually do. In case the patient comes to you after a week or maybe after 15 days after suffering with retrodiscitis, the symptoms that he presents will be more widespread. The patient might complain that the pain is now felt in the parietal region, in the temporal region, behind the eyes, behind the head, and in the head and neck region also. This is due to secondary central excitatory effects, which produce hyperalgesia, allodynia, protective co-contraction, and referred pain. Hyperalgesia is an intensified pain reaction to a stimulus that is not proportionate to it. Allodynia is pain on light touch, which means that any non-painful stimuli now starts producing pain. Protective co-contraction is a reduction in mouth opening that is secondary to pain, and referred pain is all the pain that is felt by the patient in the head and neck region and the parietal and the temporal region. If this acute retrodiscitis and is left untreated, then the patient might enter into cyclic muscle pain and chronic centrally mediated myalgia. These two are pain disorders characterized by continued pain even when the original source of pain has healed. So the patient forgets now that the original source of pain was the temporomandibular joint in chronic retrodiscitis. He is not able to pinpoint the area of pain. He just tells you that the pain is felt on the entire half side of face in case only one joint is involved, in the head and neck region, and the pain on function, that is opening and closing and mastication, also disappears. So now the pain has no relation to function, which may be very misleading to most of the clinicians. Coming on to the patient's case history, this patient has presented to us with acute retrodiscitis. She reported within 3 days of development of pain. Let's listen to her history to appreciate how all these symptoms are reported by the patient in her own words.
Hi Julie.
Hi ma'am.
एज क्या है?
21 years.
ठीक है, क्या हो गया?
एक्चुअली मुझे पेन हो रहा था, यहाँ पे स्टार्ट हो गया था परसों से ही, तो बस उसके लिए आई थी.
ठीक है, पेन कैसा पेन हो रहा था?
माइनर पेन, मतलब अपने दांत है ना से क्लोज बंद नहीं कर पा रही थी राइट साइड का.
ठीक है, और लेफ्ट साइड?
लेफ्ट साइड नॉर्मल है.
लेफ्ट साइड नॉर्मल है. लेफ्ट साइड के टीथ भी क्लोज हो रहे हैं?
हाँ जी, क्लोज हो रहे हैं.
राइट साइड के टीथ ऐसा फील हो रहा है कि क्लोज नहीं हो रहे हैं? अभी भी ऐसा फील हो रहा है?
थोड़ा थोड़ा. कल से बेटर है, बट
कल से बेटर है. कैसे स्टार्ट हुआ?
कैसे मतलब सोते टाइम ही मुझे हुआ है, फील हुआ. जब मॉर्निंग में उठी तो यहाँ पे पेन हो रहा था और ये साइड के जो दांत है क्लोज नहीं हो रहे थे.
ठीक है. एक रात पहले कुछ कड़क खाया था?
याद ही नहीं है मुझे तो.
ऐसा कुछ नहीं है?
सोते सोते ही हुआ मुझे लग रहा है.
अच्छा, सोते सोते हुआ है.
हाँ.
कुछ स्ट्रेस आसपास?
हाँ, स्ट्रेस लिया है.
स्ट्रेस लिया है. ठीक है. और इसके अलावा मुंह खोलने में कोई प्रॉब्लम?
अभी तो नहीं है, बट हाँ इस साइड से माउथ ओपन करते तो पेन होता है.
ठीक है. कुछ कड़क खाने में प्रॉब्लम?
हाँ, वो तो है इस साइड से.
हाँ, ये सिर्फ 2-3 डेज से ही है ना? ठीक है. और हेडेक या कुछ और?
हेडेक होता है.
हेडेक होता है
कभी कभी.
कभी कभी. नहीं, अभी इसके साथ में कहीं और रेफर हो रहा है, मतलब कहीं और पेन हो रहा है क्या?
नहीं बस
इसके साथ ही बस अभी तो सिर्फ कान के आसपास के एरिया में है.
Talking about clinical examination, you will find that there is pain on palpation over the temporomandibular joint if it is acute retrodiscitis, and all the other masticatory muscles and muscles of the head and neck do not produce any pain on palpation if it is acute retrodiscitis, or they may produce pain on palpation if it is chronic retrodiscitis. There will be a limitation of function in these patients, and this limitation of function will most often be due to pain. The most important clinical diagnostic examination that I follow is the tongue blade test. Whenever you ask the patient to bite on the back teeth, it will produce sharp pain in the temporomandibular joint area. But if you place hard tongue blades between the teeth on the ipsilateral side and ask the patient to bite firmly, it will cause a relief in those symptoms. This is characteristics of intracapsular temporomandibular joint pain and also inferior lateral pterygoid pain. But you can distinguish the inferior lateral pterygoid pain and the intracapsular temporomandibular joint by another functional test, that is biting on the tongue blade and protruding against resistance. If biting on the tongue blade and protruding on the resistance produces pain, an increase in pain, then the pain is coming from the inferior lateral pterygoid muscle. If the patient has relief in biting on tongue blade such that even if he or she protrudes against resistance and there is no increase in such pain, the pain is relieved, then the pain is actually due to intracapsular reasons only. So that's a separate topic altogether. But you can be sure that in retrodiscitis, when you put a tongue blade and ask the patient to clench, there will be relief in pain on the same side, while if you remove the tongue blade and ask the patient to clench, there will be a lot of pain on the same side. Now let's talk about how to treat the disorder. There are two aspects to the treatment protocol. First is management of acute symptoms and second is definitive treatment. Management of acute symptoms is done by administration of analgesics and anti-inflammatories for fixed number of days in time-bound manner. The drug of choice for me is ibuprofen 400 to 600 milligrams 3 times a day with antacids in a time-bound manner. I typically tell the patient to take it 9 a.m., 3 p.m., 9 p.m. In case the patient's history tells you that the cause is a macrotrauma, then you might need to add corticosteroids to subside inflammation due to trauma. In case the patient history tells you that the cause is from a spreading infection from ear, then you need to prescribe antibiotics and an ENT needs to take care of the concerned pathology. In case you feel that the patient had a pre-existing disc derangement disorder that worsened because of a transient phase of stress or because of some drugs which have side effects, that is parafunction, then you need to ask the patient to get those drugs replaced. And if you think the factor is stress, you can ask the patient to observe some low level of stress. You also have to institute physical self-regulation techniques, that is smaller bites, slower chewing, softer food, and restricting mouth opening within painless range. These symptoms, these all treatment protocols will help to subside the acute symptoms really fast. Coming on to definitive management of retrodiscitis. Now, definitive management will be determined by the cause of the disorder. So, if the patient history indicates that the cause is macrotrauma won't be repeated most probably. So no definitive treatment will be required. Only acute management with analgesics, antibiotics and corticosteroids will suffice. In case the patient history tells you that acute disc derangement disorder like disc displacement with reduction or without reduction is the cause of retrodiscitis, then management of the primary disorder will help in definitive management of retrodiscitis. For example, in disc displacement with reduction, you will have to administer a repositioning appliance. In case of disc displacement without reduction, you will have to give a permissive appliance, and likewise. In case you feel that the patient already had a disc derangement disorder and there is just a transient phase of stress or some drugs that have